Hello.
Good day, Alex. Brian Kelleher here.
Hi, how you going?
Good. How are you?
Good. Just making sure you can hear me. At least you can.
I can. I think Francesco and Josefa are doing a little bit ahead of me.
Okay.
Hi, Alex.
Buongiorno.
Buongiorno. How are you?
Very good. How are you?
Yeah, good. Nice to see you.
You too.
Do you notice anything strange about my look? This is my,
your glasses and your hair.
My
Last time I saw you, you had hair.
I know. Well, that is true also, but the most recent is I can't see anymore.
Oh, are you long-sighted or short-sighted?
Yeah, I suppose the long-sighted. Yeah,
Right.
it's age-related apparently. I thought I was beating it, but anyway, it's a new world. It's as of the last month. So we hear you well. That's good. You might know Brian. Otherwise, I introduce you each other.
Hi, Brian.
Hey, Alex. Yes, you've probably seen him from the Department of Health. I look after a branch in there that with private health insurance regulation in private hospitals.
Very good.
All right. Hi, Jennifer.
Hi.
How are you?
Good. Nice to see you.
Very well. Thank you so much for making today. I introduce you to Alex from the Productivity Commission and Brian from the Department of Health, Professor Millman, our Pro Vice Chancellor. Welcome,
Hello.
everybody.
Thank you. Is Henry joining us?
I hope so. Yeah, he said he was.
Okay.
I'm gonna drop him a line. Jennifer, so well, we'll see how we go, but in a couple of minutes, you can open proceedings, and probably Josefa will give us the go ahead. If she's there, yeah. Let's see. I'm gonna write to Henry now.
So I'll keep my comments really short.
Sure.
Introduce you.
Thank you.
Just noticing it's very odd. My name is misspelled. I don't know why that is on my.
Oh, I'm sorry. Where in the Zoom?
Yeah.
Uh-huh.
I don't understand. It comes up correctly in my profile.
That's
Anyway, it
bizarre.
doesn't matter. It's like Milan, the city, but with an M at the end.
Yeah. All right.
I don't know how that. Anyway, it doesn't matter.
Yeah. You Milma. Yeah. You. I don't know how you can change that, but
Don't worry about it. It's not important.
all right. Let's just check with Josefa. Josefa, you there? Here is Henry. Hi, Henry.
Good morning or good afternoon or whatever the time is for you.
Thank you. Good morning to you, Henry, from Paris, I assume. We hear you well. You hear us well?
Yes.
Very good. I introduce to our Vice Chancellor, Professor Milam, and of course, Alex, and also Brian from the Department of Health. Welcome. I think we wait 1 minute. I'll try with Alpha. Sorry he's probably running late. Josefa, are you there?
Yes, can you hear me?
Yeah, all right. So I suppose we start now. So if you want to start recording and then okay, Jennifer, please.
Okay, great. Thank you. Hello, I'm Jennifer Milam, Pro-Vice Chancellor of Academic Excellence at the University of Newcastle. And I'm very pleased to be here this afternoon to open this first debate on healthcare system reforms that is being hosted by the Value in Health Economics Policy Group, a very active group recently that's been looking at the effects of COVID-19 globally and producing a great deal of information for all of us to understand the turbulent times in which we live, times that are not quite post-COVID yet, I don't think, considering the number of people who are absent from my building, at least today, and I'm sure around the world that remains to be the case. But as we turn into this new COVID normal, I think we do want to know a great deal more about how we look at global socioeconomic instability and what we can learn from others around the world. But first, we're going to look at the Australian case through this debate on healthcare systems reform. And I'd like to introduce here our chair for this afternoon, Professor Francesco Paolucci. So thank you very much, Francesco, and over to you.
Thank you, Jennifer, for the introduction and opening. I would like to introduce our panelists. Of course, I introduce first myself as the chair, and the co-chair is Josefa Henriquez, both from UN, the business school, in fact. We have really the pleasure today of hosting a very distinguished group of speakers from the Productivity Commission, Professor Alex Robson, who has held many appointments in Australian government, in academia, and very recently at the OECD in Paris. So welcome, Alex. Alpha D'Amato, welcome, Alpha, Deputy Secretary, Financial Services and Asset Management and CFO at New South Wales Health. Welcome, Alpha. Brian Keller, who's been with us in previous meetings, also Alpha, in fact. Welcome, Brian is Assistant Secretary, Private Health Industry in the Department of Health, overseeing a number of very timely and important projects that are at the heart of really reforms that matter in the Australian context, but I believe also globally. Thank you, Brian, for joining us today. And Professor Henry Ergas, columnist for the Australia. Henry CV is extremely rich and long, and I will mention a few things. Of course, his experience in the OECD and in consulting on a number of very important issues in Australia and globally, from telecommunication to aged care to healthcare, and he's connecting with us from Paris, if I'm correct. So welcome, Henry, and for making the time to join us today. So I would like to kick off today's debate, as Josefa mentioned, as Jennifer mentioned before. We are trying to conduct a monthly meeting or debate on reflections around healthcare systems, and in particular healthcare systems reform, as there is a global push to try and really address some of the issues that have been rising in the last 2 years with the pandemics, and probably some have been exacerbated by the pandemic itself. So we start, of course, with Australia. We will have other meetings going a little bit around the globe. But today we focus on Australia, and I probably would like to ask Professor Robson with a question around the works of the Productivity Commission, which is a peak body in the Australian public sector that really looks at a number of important economic and social issues. The Productivity Commission publishes a range of reports, and in particular it focuses on some data on performance, in particular on healthcare. This is done, if I'm correct, yearly. So in its report on government services publication, what do you think are the most important and recent trends that we need to be aware of, and what are your thoughts about them?
Yeah, thanks, Francesca, and thanks for inviting me to the panel today. I guess by way of sort of setting the scene, I think we're seeing, I guess, the return or revenge of capacity and resource constraints. And that's, important in all sectors, but in particular in health, and sort of trade-offs. Although at the beginning of the pandemic, governments were focused on sort of solving a range of very urgent issues, the trade-offs started to quickly emerge, and now we're seeing that in the data. So if we look at the ROGS data that the Productivity Commission sort of publishes annually, the trade-offs that started to emerge in health since the beginning of the pandemic are quite evident. So there was, for example, declines in breast screening rates for all women, with the largest decline in Victoria, and some of the declines pretty pronounced. So 14% reduction in Victoria, 12% in South Australia, and that's evident in other indicators as well. So bowel cancer screening rates have declined as well. We saw, though, dramatic reductions in rates of whooping cough and other childhood illnesses. On the other hand, children accessing MBS subsidised mental health services has gone up by 20%. So there's this range of outcomes that occurred during the pandemic, which show that it did have these impacts, and these trade-offs are quite evident. And when you're designing not only pandemic policies but health policies more generally, you've got to be aware of these trade-offs. And in the current economic circumstances, not only in Australia but around the world, I guess that's where we are at full capacity, and resources are being used fully, both in terms of capital and in labour. And so the question then is, really, how do you improve productivity to shift the frontier out? And in health, we know that can be quite difficult because of the nature of the goods, the nature of competition or the absence thereof, contestability, government provision. All of these aspects of the health system make productivity improvements very challenging. So that's just by way of setting the scene. During the pandemic, and now, as we sort of, I guess, hopefully move towards the later stages of it, we really are seeing the revenge of capacity and resource constraints, and that makes policy making in this area sort of all the more urgent in terms of reform, but also making sure that every dollar that's spent, has maximum benefit. So that's just by way of setting the scene, but that's what our data has shown, these important trade-offs during the pandemic.
Thank you, Alex. Maybe going to Henry, following on this point. So, in essence, the debate around the fundamental features of healthcare system is now again being raised in a number of countries. Some are really going for a more social insurance, competitive insurance type of approach. Some US style, some more European or Dutch style in a sense, with universal coverage, but with clear purchasing functions. And this debate is clearly happening also in countries where historically it hasn't happened, including, for example, Italy in the past year or so. Now, that has also been the result of the performance of some of the let's say decentralized healthcare systems in the European context. The Lombardy one in particular was heavily hit during the pandemic, which has gone through profound privatization, but under the umbrella of a public system. So many economists globally have started looking at this more closely, questioning the idea behind having quasi-market, or if you like, these bilateral monopsonies, in other words. So one single public buyer versus a competitive model. What are your thoughts about this tension in a very rich, or as some say, fragmented, multi-funding governance model that Australia has, Henry? We can't hear you, Henry. You're muted. Sorry.
Sorry, apologies. Thanks, Francesco, and thank you also to Alex for his preliminary comments, which I found very interesting and very helpful. To my mind, there are some immediate questions and then some longer term issues which will have to be addressed. And the structural issues that you raised, Francesco, certainly go to those longer term questions. The starting point, I think, really for our discussion today and the context within which those longer term issues will need to be seen, the starting point is what's happened in the pandemic, what lessons can we draw from it, what is likely to happen going forward, what tensions has it highlighted, how capable are we of addressing them. To my mind, the great issue which arose in the immediate context of the pandemic was the issue of the surge capability of the healthcare system and of the systems around it, including the aged care system. And I think the jury is still out in terms of an assessment of how well the Australian system performed in that respect, how much surge capability it proved possible to provide, and how well the interaction between the public and the private sectors worked in trying to address the need for that surge capability and to increase that resilience. I haven't seen any particularly careful assessments of that at this point, but it's obviously an important part of trying to draw the lessons of the pandemic going forward. I think the pandemic as such has some significant longer term implications, which again, I'm not sure how much progress we've made in assessing. One element of those implications is simply the result of the factors Alex pointed to, that during the pandemic, there was the deferral of a great deal of healthcare, and what the long-term signature of that will be and how it will be allocated within our system, where the pressures will come. I think that's an issue that will be worth considering. But as well as that, the pandemic acted as an accelerator of some trends, or at least heightened some trends. And perhaps the most significant one, which Alex again mentioned, were the issues associated with workforce shortages. Now, that is such a fundamental issue at the moment. Obviously, especially acute in aged care, where we have the paradoxical situation where the aged care sector is heavily dependent on the Australian Defence Force to provide services that, in theory, it should be entirely capable of providing, and it is funded to provide. And that's an entirely unsustainable situation. But the aged care sector is not alone. The problems arise also in the hospital sector and equally in the NDIS. And so then the question comes back to, are those shortages the transient result of special factors that have been at play in this situation, including the slower growth in the labor force due to the restrictions on migration, or are they enduring, in which case, what are the levers that policy has to deal with them, including through higher productivity, better labor utilization in the sector. And that's really where the link, I think, comes in between the immediate aftermath of the pandemic and those structural reform questions that you raised, Francesco. And so if one had to deal with them, I would suggest thinking about it this way. Let's try to understand why those issues of capacity constraint have all of a sudden become so, they've always been there, but have all of a sudden become so dramatically acute. Try to understand the extent to which they are now a permanent feature of the landscape. And I believe that for a range of structural reasons they are. And then assess what the best instruments policy might have to try to relieve them.
Thank you, Henry. That's very interesting indeed. Thinking about this issue of workforce, Australia is one of the very few countries in the world that really has, I would say, a model of pricing for healthcare services, in particular for services that are delivered by physicians, that is uncapped. We experience that every day, or not every day. I mean, hopefully not every day, but some of us on a daily basis when visiting a GP. We have the bulk billing amount, but then you have an extra amount to pay unless you're in a Medicare card situation. That amount is really determined by factors that are typically related to the geography where you live, which is clearly connected to income levels as well. But it's pretty much a free price setting environment. France is another country that has that particular feature. Most other countries have some form of capping. Most countries that have a national health service, for example, do that. And you know, often the debate has been not only in Australia but globally about the effects of capping, and obviously some debates have been held also here as well. But the appetite for it is clearly controversial. There are advantages and disadvantages in every way you look at those type of policies and so on. But what we observe, or what has been discussed in the past few months, has been the fundamental rise of out-of-pocket payments, which is partly a reflection of that. I would like to pick Brian's brain now and comment on what are his feelings from government around out-of-pocket payments. I know that there has been quite a lot of attention on these issues. A number of projects have been conducted. So what are your considerations on this and workforce?
Thanks, Francesco. I might just make a quick comment about some of the things I've heard and then go to out-of-pockets. One, I don't want to lead the debate, but I'm really interested in what Alpha might say about Henry's question about where COVID took the public system in terms of contracting with some private suppliers to deal with surge capacity. And I think, at least from my perspective, I think we've had an experience there, and the learnings are probably going to come. But that may be one of the silver linings, I think, in terms of the COVID piece, in terms of some of that engagement between the public and the private sector. I'll also make a quick comment around this point about deferral of services through COVID. And I think it's a really interesting thing that I'd say with confidence, where we have services, particularly diagnostic services, that have got a strong evidence base for delivering, you know, people accessing that service, then we should expect that there'll be consequences when COVID has disrupted access to it. But I think there's a broader issue, and maybe it's a subject of a different conversation, is how much of that service that wasn't delivered had a strong evidence base that it was necessary. And I think in terms of a discussion about how we make use of existing capacity and our resources, is having the confidence in the evidence base for that we are delivering services that make a difference in terms of the healthcare outcomes. Because I think a little bit of the issue that you were mentioning, Francesco, in terms of the Australian situation, yeah, uncapped payments, particularly in the private sector. But we also have a model where it's essentially set up that we're promoting the maximisation of the number of encounters with the system. We're not maximising healthcare outcomes. A lot of our payment regimes and incentives is about interacting with the system. So there's a couple of things, but just to get back to the out-of-pockets point, let's just put the consumer in the picture here. What the work we're doing in terms of trying to promote transparency around out-of-pockets, to at least empower the consumer to have some visibility of what services might give rise to an out-of-pocket and what is the out-of-pocket that they're likely to pay look like relative to other providers. So just transparency around where are these out-of-pockets occurring, what is the magnitude of an out-of-pocket for one service provider relative to another, I think is really important. And particularly in the Australian context, where these services are being delivered as a private service with significant government contribution towards it. And for some of those, there's a private health insurance contribution. And that the question then becomes, where does the value start to kind of dry up for the consumer in terms of government contribution, their contribution through the PHI, through their private health insurer? What then is a reasonable expectation to pay over and above that. And ingoing is they should at least have transparency of what those rates are. I think the harder question becomes, well, yes, should government put a limit on what it's going to contribute and what others can actually charge if they want to play in this private-public space of some government money and some co-contribution, as opposed to government contribution being capped and an uncapped private contribution. I think that's the harder question, but I think it goes to the nub of the issue: what terms and conditions government's going to put around payments for something that is essentially a private-public partnership for the delivery of the service. I hope I expressed myself well.
No, thanks. Absolutely. In fact, I have an immediate follow-up that brings me to Alpha. So what we hear, in fact, also for the benefit of the audience attending today, it's a multi-payer system, but fundamentally the purchaser is still the individual by and large, right? So he's the real shopper, and then someone contributes to that cost unless you're hospitalized through emergency. That's basically the story. Now, during the pandemic, obviously that is a very unique model. Before I go to Alpha, many countries have delegated to one single purchasing entity, particularly social insurance countries or insurance-based model. They have this delegation, sort of the prudent buyer of care on the behalf of the consumers, with advantages and disadvantages that really call also for a sophisticated contracting function. Now, going to Alpha, I think in the COVID experience that has happened at the state level, where in fact, and this is my personal impression, but by and large, the states have been found themselves in playing a bit more actively the role of purchaser, also in areas that where historically not necessarily their competence, right? So even primary care or GP care and so on. So there has been this kind of partial novelty, right? So it would be interesting to know what's your experience from a New South Wales perspective about this innovation in practice, in essence, and what you think can be retained and even perhaps in a sense, retained and perhaps even considered for structural change.
Thanks, Francesco, and good to be back. I think that it's fair to say that some of our experience has been probably on the reactionary side. Yeah, independently, I think there are plenty of lessons that we are now considering, lesson learned that we can consider for future, if you want, developments, or whether the structural changes or not. The unfortunate situation that I think we need to acknowledge is that we are still in an environment which remains fairly volatile. And I think it certainly plays against us, in particular when we try to then interface with the private sector, whether it is to address the fair care, whether we're looking at the PCR tests and the like, because it's very difficult to say how long for, whether we actually contracting, whether we try to purchase. And that volatility is certainly, probably to remain in the short term, there's no doubt, but it certainly create a challenge for us to then have a better engagement model with the private sector. The other part I also think we need to reflect on is the capacity constraints, and the capacity constraint, I think, has been well addressed from all the panelists in regards to the workforce, but there's another constraint, which is the physical constraint. And I think that is mainly driven by the failure of the aged care sector, where we do have a lot of our hospitals currently occupied by aged care patients. They are not able to discharge, and all primary care, where we see that GPs at the moment are not necessarily, if you want, they are referring many of their patients directly to emergency department. So again, all of the kind of constraints around the capacity creates even more challenges in planning on how we can better then contract with private sector, planning our resources and also the workforce on when we really need to bring it in. And to find my final comment is that ultimately we're all competing for the same resources, for capacity as well as workforce. Whether it's the private sector, they all need nurses in the private sector as much as we need them, and the aged care. So I think that's probably, from my point of view, these are some of the challenges that are currently, we are currently unpacking. And going forward, I can see that many of these challenges have created opportunities, but I don't see that these opportunities can be realized in the short term because of this volatile environment.
Thank you, Alpha. Maybe I follow up with you on one question that relates to this. What we observe also in the during the COVID pandemic, in fact, is that a higher degree of centralization in decision making, also purchasing decision has occurred to a large extent. And now, perhaps in a so-called post-COVID era, perhaps only from the point of view of the intensity of the rules rather than on the evidence around cases or the impact of the pandemic in itself and the so-called collaterals related to it. What we see is a push towards decentralizing decision making. I think this is happening, of course, in Europe, in many countries where reforms are being presented as we speak in many regions, in Italy, in Spain. In fact, this is happening. Of course, some ideas have been floating around also here, even at the level of LHDs in New South Wales, where further decentralization or even splitting some of them might be on the cards. With the COVID experience fresh, what are your thoughts about these trends as well?
Look, first I need to qualify that my answer is reflecting the corporate services, so the procurement aspect, the financial services. And I can tell you that, in fact, just this morning, we were reflecting on some of the lessons learned around the procurement of medical consumable, which has been centralized as a result of COVID. And the lesson learned indicate that we should maintain a degree of centralization. The opportunities of central purchasing, statewide contracts certainly outweigh the risk of the devolving back to the districts, the ability to procure directly. So I see that from the corporate side, there are good opportunities, and I think there is a significant support from the districts system to actually maintain a degree of centralization, provided that there is a degree of transparency around the data, which we didn't have before. So I guess there is a bit of a win-win from my point of view. One is that there is a fiscal, advantage because we'll be able to better contract with the vendors and drive price down, in particular in this current environment, all the prices going up. And the second, provide a more centralized access to data for transparency and benchmarking that can actually support the districts in making their local decisions. So centralization is likely to stick around for a little bit longer.
Thank you. Thank you so much. Now, I would like to go to the audience now. We've had some questions coming in. I think they connect quite well with our discussion. So one directed to Alex, but I would also like Henry's thoughts on this. Basically, the question goes like this: is there a trade-off in what you see, improve productivity plus push frontier out versus build some deliberate stack capacity in system? For example, deliberate capacity constraint might improve productivity and efficiency, but as what is the impact, in fact, on prices overall? Is that clear enough? I can rephrase it, but I think it's well formulated, and I think it's very much the heart of your point. Yeah.
I'll have a go at it. Thanks, Francesca, and thanks for the question. I think it goes to the, and we saw this particularly in Europe. You look at the differences in systems, say like Germany versus Italy, in the number of spare beds, at least at the beginning of the pandemic, and whether there's a sort of trade-off between, for want of a better word, I guess, resilience in the system, or the ability to cope with shocks, and efficiency. And if I think about efficiency in the broader context, I don't think there is. I think it's having a resilient system in a sort of dynamic efficiency context, it is part and parcel of the broader notion of efficiency. So I think if we think about the pandemic, it increased the probability of some adverse events, and having some spare capacity or having a surge capacity or different ways of dealing with that is a form of insurance. And once you have this change in, the actual probability of an event, you may have underestimated it in the past, but now we've had the experience. I think you've got to adjust the way you insure against that kind of event. Now, whether that's just empty beds laying around, or whether it's provision for some sort of special surge capacity that can be ramped up very quickly, that needs to be assessed on a cost-benefit basis, and might depend on a whole range of other factors. But I don't think that there's necessarily a trade-off between those two. I mean, if you measured productivity very narrowly at a static point in time, and you just, there's empty capacity or spare capacity, that you'd say, well, productivity is very low. But if you measured it in the broader context, taking into account these other risks, and properly measured it, you may get a different answer. So.
Thank you, Alex. Henry, would you like to comment on this?
Well, I agree with Alex that there certainly isn't an inherent contradiction between having a system that's resilient, in the sense of a system that has the capacity to deal with shocks that either reduce supply or increase demand, or both, and having a system that has high levels of productivity. On the contrary, you would think that resilience in the face of shocks is one aspect of the efficiency of any system, and of the healthcare system in particular. So in that sense, I certainly share Alex's view. Obviously, the issue is how one works through that and deals with it as best one can, and then what the immediate challenges are in starting along that path. I dealt with this some years ago, actually, in an entirely different context, which was when I was on a review of defense procurement. And as you can imagine, in a defense context, it's absolutely critical to have a capacity to deal with sudden surges in demand, or i.e. with situations where the requirements increase greatly, often correlated with other changes, which make meeting those requirements increasingly difficult. And what you essentially have to do, at least in my experience, is use a very broad range of mechanisms along the lines that Alex hinted at, going from inventories of spares, excess beds, for instance, in a hospital context, through to quite complex contracting arrangements that can be triggered as a contingency eventuates, or as the probability of a contingency eventuating rises. And to my mind, what needs to be done as we emerge from the experience of the last couple of years is to look back at, well, what worked and what didn't work in the surge context. And I'm heartened by the fact that New South Wales is doing that and learning lessons from it. Obviously, I think there's a great role for an institution such as yours, Francesco, in terms of articulating those lessons, sharing them, and testing them, and making them more broadly available. That I think is really quite fundamental. Could I just make one other point, which goes to some of the things that were raised about centralization and decentralization, which is this: that to my mind, one of the events which occurred more or less in parallel to the pandemic, though predated it and obviously will post-date it, but that had very significant effects, particularly in the aged care sector, in terms of the shocks that it experienced and the difficulties that it has had to cope with, has been the spectacular increase in expenditure on the NDIS. Right? The NDIS has become, from being a relatively marginal component of the healthcare system, or of the system, however you want to define it, to being a very large consumer of resources that competes with important parts of the system. And so we've added this element that is almost entirely uncoordinated with the rest of the system. We've added this element that has delivered a huge demand shock to the system in terms of resourcing. And that has aggravated every known problem. Now, that's not to say that the NDIS should not have developed. I'm not saying that at all, or that its development is a bad thing. My point simply is that in terms of the effective degree of overall coordination in the system, particularly in terms of human resources, at the level of just arms and legs, as it were, that is so vital in hospitals, but also in, particularly in aged care. In terms of coordination, we really undermined it extremely significantly. And the consequences of that, I think, will reverberate for many years to come. And unless we face up to those consequences, the current crises will continue.
Thanks. I think this is an excellent point, which, in other words, brings us back a little bit to the fundamental question, which is how complex it is. And Rod actually mentioned this with his own words. Thanks, Rod McKinsey. The previous questions were from Andrew Matthews. Thank you, Andrew, as well. But they bring us back to the issue of how difficult it is to actually price risk in healthcare for a number of reasons, and often that complexity, which indeed relates to the failures in healthcare markets more broadly, are manifesting in realities like the ones that we experience in Australia. Henry pointed again to a new, relatively new pillar in something that we would refer to as health in other contexts, which clearly deals with the needs of disabled individuals, but nevertheless has clearly attracted a lot of resources and definitely increased demands that add to the multiple pillar system that we now have, which is again a system of multiple payers. Nevertheless, with differences, fundamental differences in when we think about, in fact, who's buying the services. And again, the consumer seems to be the central, and probably from an economic perspective in this market, as in many other markets subject to market failure, really the least best equipped to make some of these decisions. So now there seems to be a more philosophical, perhaps, discussion coming back, that is really the tension between choice, which almost is something that belongs to the private insurance, private sector, sort of thinking, whereas in the public system, we always think about rationing. Lauren, who also contributed some of the rationale around why priorities in times of crisis are set to forgo some important services, because the focus of the workforce in the public sector is clearly on the top priority at the moment has been COVID for a while. But going to this issue, and I would like clearly to ask Brian a little bit. Of course, Australia as an interesting player, which is the private insurance sector, really, that is duplicating, supplementing, complementing, if you like, the public system. Obviously, it offers choice for individuals and so on. It has a number of regulatory tools, in fact, that attract, including attracting subsidies or tax deductions and so on and so forth, which are quite unique to the Australian system. In some other NHS or national health insurance models, like the UK or Mediterranean countries or Scandinavian countries, that wouldn't be the case. So now, during the pandemic, sorry for the long introduction, but I'm trying to clearly direct the discussion a little bit. During the pandemic, many have seen private insurance as being somewhat on the back foot, a bit dormant in dealing with the emergency. Now, there is clearly an increasing attention towards what it's next 20 years, 10 years, 5 years, not sure what's the time frame you would like to look at it, but definitely an opportunity to revive and reinvigorate its role in the Australian system. What are your views about the private insurance market, Brian?
Thanks, Francesco. Just to check, how's the audio? Because there was a comment that perhaps it was a bit faint.
I can hear you quite well.
Excellent. And so just a quick comment around choice and private health insurance. I think it's such a broad concept, and I think it means different things to different people. From the perspective of a purchaser of private health insurance, and I don't want to overstate the benefits or the range of choice that private health insurance provides, because I'm not sure in all instances that consumer or that patient is well positioned to, or has the actual authority to make lots of choices. I think they've got some upstream choices about the type of product they buy. They've got some upstream choices about who that initial care provider is. But as they enter their care journey, I think sensibly their amount of choice that they have to them starts transitioning more to the care provider and relying on their expertise. And so that's a comment around choice, and I think it goes a little bit to what the value proposition or what the intent of private health insurance is. To a certain degree, yes, there's choice is a little bit of the payoff, I think, for those people that are investing more of their own money in their healthcare. And that's, broadly speaking, a perspective on how we've set up private health insurance in Australia, with the way Medicare levy surcharge kicks in to obtain participants and to maintain participants in the private health insurance market. what might be one perspective, when you gave me a 5 or 10 or 20-year horizon for private health insurance, I think the 40-year horizon that kind of I've been looking at recently and revisiting is the one that our Treasury set out in a generational report, where they say health spending is going to double. What's the major driver of health spending? Perhaps it's our ageing population, and it's the increasing prevalence and consequences of certain chronic diseases. What then is the sort of private health insurance in that sort of environment, where we currently have them largely constrained to funding the delivery of services in high-cost facilities? There might be a role for helping them, or there might be a role for private health insurers helping their customers do something early on in their life to avoid, delay, diminish their exposure to requiring that high-cost care in a hospital, letting them get access to preventative health, engaging them in activities that will benefit their long-term health outcomes. So I think that's supporting their engagement with private health, primary health. How we do that is an interesting issue, but I think in terms of the role that insurers would play, we could have a design decision here where you keep them just playing in the high-cost space, and they'll have consequences for the affordability and the ability for people to participate in that, because it's going to continue to be expensive. Or you think about what contribution they can make to assisting people to deal earlier with chronic disease conditions or even prevent them. So there's a couple of angles, and hopefully people will react to that. So over to you, maybe Henry.
Yeah, Francesco, if I could. Look, I think the situation with private health insurance in Australia is in some respects stable, in other respects dire. It's stable in the sense that if you look at the numbers insured and proportion insured, it's essentially been stable over the last couple of decades as a proportion of the potential pool of enrollees. So in that sense, there's a degree of stability, but it's dire in the sense that that stability has been obtained really through massive policy intervention and ongoing policy intervention, including through considerable financial support, but also by virtually coercing or at least taxing consumers into PHI through the Medicare levy surcharge. And it's also dire in the sense that the stability has occurred despite the fact that real incomes in Australia have increased very markedly over the period. And you would expect that in a situation where we had, admittedly with some slight interruptions, but nonetheless very sustained growth in real incomes, you would expect the demand for private health insurance to be income elastic. And so you would have expected that the proportion of the population that would choose private health insurance would rise over time. Well, that, as I say, hasn't happened. And that begs the question of why we remain in this situation. And I don't think this is the entire answer by any means, but it's certainly a part of the answer, is that we've been extremely unclear, if not positively confused, about what we want PHI to do, why it exists, why we fund it, why we have it, and what function we ultimately want it to play. And nothing, I believe, highlights that more starkly then the philosophical issue you raised at the outset of this immediate discussion, Francesco, about the sort of balance between choice and, in a sense, coercion or compulsion or control, however you want to phrase the antonym to choice. And in a sense, the peculiarity of the Australian situation is that we've cast PHI as the element of choice in the system, but increasingly we've wanted it to play the role of, rather than being the element of choice, to be the means of controlling costs, of putting pressure on the system to ensure it provided the value for money and was cost effective, all of which involves the kind of control, if not coercion, that you see in systems such as the Dutch system or some aspects of the American system. And we have stranded the PHI sector really between the competing demands of offering the prospect of choice to consumers, but then at the same time, somehow controlling those choices so that it can act in the system as a way of deriving higher productivity and greater value for money. And until we're clear about the balance between those respective attributes of the private health insurance system and of the role it plays in our health system overall, then I fear that we will simply continue in this situation where the PHI component of healthcare remains viable, but never really makes the transition to robust good health.
Very, very interesting point. Wants to comment here? Otherwise, I'll follow up.
I was going to comment on something that Brian had mentioned, Francesco, just on preventative health and private health insurers. I mean, I guess the difficulty, I mean, it's for private and public sector alike, is, you know, encouraging, well, will insurers have the incentive to want to insure or take whatever action it is to, you know, when the link between, you know, the action that an individual takes today in terms of prevention and the possible benefits, you know, 10, 20, 30, 40, 50, you know, it's such a long period of time. And, you know, and that's a difficult, yeah, that is a difficult problem to solve, I think, for an insurer. You know, you can imagine, you know, insuring against, you know, accidents and so on, where the link between an action and the consequences is pretty, you know, is more or less direct. But the link between, you know, a decision that I make today and then my health in 20 or 30 years' time is far less direct. So I guess that's the challenge. And, you know, and it's just part of the challenge that Henry was talking about in understanding the role of private health insurance. But if you were thinking about the preventative health, you know, and some things are, you know, the link is very obvious. So it's like smoking, alcohol consumption, that they're very, you know, you know, the links there are pretty direct. But others, it's, you know, it's far less direct. Yeah.
Sorry, Alex, if I may, I think there's two additional elements to that. One element is that not only is the link often, not always, but often rather long-term, but essentially the benefit of the prevention today may not accrue to today's insurer.
Correct. Mm.
In a system in which you have mobility both within PHI and between PHI and non-PHI, then the investment that is currently made in prevention may ultimately either benefit someone else or be an externality to the system as a whole. And there's a further element which has always complicated these issues associated with encouraging investment in prevention, is the fine line between measures that look like preventative health and measures that are really means of risk selection. So, for instance, if I subsidize people to go to the gym as a PHI insurer, which may well be a sensible thing to do from the point of view of long-term healthcare, but it's also a way of attracting younger consumers and repelling the kind of consumer who isn't particularly interested in going to the gym. So it then alters the risk pool and selects in the risk pool with what may be, again, externality or external effects on the system as a whole.
Very good points indeed. Probably a natural follow-up to this, which really stems from Henry's points that I tried to summarize briefly. The first one is, what's the role of PHI, which, you know, in a sense also asks what's the role of let's say the public insurance scheme that we have, because it's clear that healthcare at the state level is providing hospital care. I mean, that's the essence of it. And at the Commonwealth level, there are, if for those who are not necessarily from Australia, there are a number of schemes. Of course, Medicare, that it's a system that subsidizes the access to medical services, the PBS that does that for drugs. Of course, it intervenes also in the aged care sector. So it's kind of filling very important gaps that existed prior to 1984. Now, equally, the role of PHI as such and of Medicare are clearly not hidden, right? So what Henry is asking is really what's the role going forward. And originally, PHI, for those again that are not familiar with the Australian system, was savage in a sense after the introduction of Medicare, with a number of regulatory tools that have helped stabilizing it. But the major motivation at the time were really to relieve some of the pressure to the public health system from a public finance perspective, and in addition to increase choice. Now, going to Alpha, with all this in mind, it seems to me that when we think about the role of the private sector in general, but also of private insurance in playing, in a sense, this relief valve, if you like. Obviously, when you consider also the workforce basis that really from which really the private sector draws from, which is the same that is utilized in the public sector, what we observe, because of the complexity of Australia, which has an important rural component, is that there is an upward pressure on prices of services in the more remote parts of Australia. Clearly, there is an opportunity to operate as healthcare professionals and providers in a variety of settings: public, private, city, and remote. So obviously, the current combination, the current, let's say, interplay between the two systems is putting pressures on the public system as well. What's the trends regarding this now that we are a year after? Of course, last year everything was on COVID, but on the management of basically this scarcity of workforce in remote areas, and how is that pressing on state budgets? Although I should say, parentheses, that Australia, also for those who are not here, is very fortunate because we've had positive budgets. The rest of the world is experiencing at this moment budget cuts. So we're talking with that in mind. So Alpha, please.
Yes, Francesco, thanks. That's a good question. It's certainly one of those issues that we were experiencing even before COVID, as in the workforce in remote settings in rural and regional New South Wales has always been a challenge, in particular in certain specialties. I think that, as you pointed out, we've been very lucky, in particular with this budget cycle, where we secure additional funding specifically to address some of these workforce challenges in the regional areas, where from this financial year, we will be able to issue incentive payments to attract and retain workforce on a permanent basis, in particular in those small facilities where we have struggled for many, many years to fill the rosters. So I hope that as we now shifting our focus in implementing this new policy decision from government, that we'll be able to address some of these challenges. Obviously, it's not going to be easy. And the reality is that we're now all in the same space with workforce. Ideally, these additional incentives would have been probably more successful if we weren't all trying to attract additional nurse and clinical workforce. But nevertheless, I think that's an important step forward and towards the right direction to, again, attract and maintain, retain the workforce, and not only retain, but also provide for the clinical training to maintain the safety and quality standards that we would expect to provide in these small hospitals in regional areas. So you're absolutely right. We've been very lucky this round, and we need to make the most we can with this additional funding.
Thank you, Alpha. Now, there is a question, Alex. I would like you to there are a number of questions coming in. I'm doing my best, so apologies. Andrew Podger. Now, back on what is the main benefit of PHI today, queue jumping, that I'm reading. So queue jumping is one of the benefits that Andrew identifies, which I certainly agree to. Somehow the question has been moving around. Here it is. The serious issue during COVID has been the likelihood of that benefit not being available. What's your view on that? And to add to this question, probably it makes sense. It makes sense, at least in my mind, to link it to the attraction of, I would say, public resources to PHI as well. And how do you see these two elements connecting?
Yeah, I mean, so it's I think it's the critical question in relation to PHI is just what is the bundle of services that it's providing in terms of quality and all these other attributes. And so we tend to focus on the taxes and subsidies as a way of, as Henry outlined, encouraging people to stay in the system or boost participation. But I think, there's another critical set of questions there is, first of all, what are you actually insured against, and what can insurers, what are they allowed to provide under regulation, and the attributes of those things. But then also it's all relative to the performance of the public system. And so if the public system is performing well, then you would expect that to reduce demand for private health insurance at the margin for some things. So the extent to which queue jumping is or isn't available would be one attribute of what you can do, what you get from private health insurance, but there's lots of others as well. And so the extent to which that'll affect demand and the rest of the system just depends on consumer preferences and how they value that compared to everything else. So it's a difficult question to work out.
Yes,
exactly.
as we would expect from Andrew Podger. So thank you, Andrew. A very important point indeed. Now I would go and see another questions here. We didn't talk apparently enough about access issues, and some may frame them as affordability issues. And this conversation links back to the out-of-pocket, but I also believe it's related to the way in which we deal with workforce and price regulation of that. Certainly, that has an impact both for the public and the private sector. The Australian system, obviously, in socioeconomic disadvantaged groups in remote areas, seems to be, Andrew Matthews asks, some more difficulties than perhaps in other areas. I'm not sure whether that is a comment or a question. Probably I leave it at that. Now another comment in relation again to Henry's point, I think on risk selection, which brings us back to ways in which we want to prevent that in the private insurance market. And the regulatory tools that is mentioned here is community rating, plays a big role in government, obviously, but there are other tools. And certainly I can think of risk adjustment and prospective payment models there. So we can leave it at that as well for now. Now, okay, so let's go back to the questions around potentially around integration of the two systems. Now, playing in the last few minutes of today's conversation, playing a bit the creative moment, I would say. So we have two systems, maybe more Commonwealth, state, private health insurance on the funding side. The provision side is clearly a mix as well, depending on which silos we focus on. Clearly, what's evident is that there are a number of silos present now. What are your thoughts about not only the practicality or the efficiency, intrinsic efficiency, Henry, of integrating these multiple layers and in funding and provision, but also in terms of the politics? I think I'm trying to kind of bring together a few questions raised by the audience. In the Australian setting, is it, let's say, conceivable and integrated or more integrated or coordinated system with a coordinated purchasing function, in your opinion? We can't hear you, Ari. I'm sorry.
I would like to think that it is, and I would certainly hope that it is possible to do that. And of course, over the years, people such as Andrew Podger have done a great deal of work in thinking through how that might occur, how that degree of integration and coordination might be improved, and what the long-run function of the public and the private sectors might respectively be in that in that evolutionary process. To my mind, it is really one of the great missed opportunities of Australian healthcare reform, that the work which was done by the Healthcare Commission, by the Health and Hospitals Commission, that was set up by the Rudd government, and that came up with a view that was essentially that of a quasi-transition to a social insurance model, at least as a possibility, that had no follow-up whatsoever. And that now, more than a decade later, we are still in a situation where there's very little clarity, if any, as to how we think the system will evolve over the long run. My belief remains that that there are advantages in a competitive social insurance type model, perhaps along the Dutch lines, as you suggested, Francesco. But I don't believe that would be feasible unless there was a much greater measure of agreement than there now is about a roadmap that would eventually help us move in that direction. If you don't know where you want to go, you can be pretty sure that you won't get there. And at the moment, that's really our situation. You will know much more about this than I do, Francesco, but my vague recollection is that the Dutch basically took 15 years to work through a broadly agreed vision of the future. And once they had broadly agreed that vision, they then finessed it and obviously adjusted it in the light of experience, but nonetheless, by and large, remained within the parameters of that roadmap. And so the starting point, if we want to get there, would be to try to develop such a vision. Now, my sense is that that's not terribly likely to happen. And I hate to be pessimistic, but perhaps I'm a not entirely bleak pessimist in this respect, because I think the reason we're not likely to get there is because the situation is actually not all that terrible. It sort of doesn't, the house doesn't seem to be burning, and the walls aren't crumbling in front of us. And so what is more likely to happen, in my view, is that we will continue to muddle through with a system which is far from ideal, but also by no means the worst system in the world.
Thank you, Henry. So we need fundamentally a crisis after this. I couldn't agree more. I think it's a very I share your view. But going to the essence of your point, and then of course asking which each one of the panelists to conclude with their observation in general on the panel today. But what you're suggesting fundamentally is a vision that is basically, let's say, bipartisan or let's say a consensus base, which indeed reflects the DACA reforms in the late 90s, sorry, in the late 80s, in fact 89. So in a very ever-changing European and global political context. So going around the table for your observation on this or the panel discussions today, Brian.
And maybe I don't see the system dramatically being changed overnight, and no one would suggest it will. But I think to the extent that we're doing work, and we are doing work in the department and other areas, presenting work that digs into what is real claims experience, what is the evidence around better ways of delivering healthcare. If we can get more of that into debates and use that to inform policy settings, all the better. And I think we're making a decent start of that in terms of the reviews around the rebate, the MLS, lifetime health cover and risk equalisation. So I think getting that work done, getting that information out there and debated is fundamentals of actually moving the system along.
Thank you, Brian. Alpha.
Francesco, look, from my point of view, I tend to think that we are going through a TNT process, which is transition and transform. So the parties we need to pick item by item and see what we can transition back to a BAU and which one we can not only transition but transform. So the example I gave you before is one that is a good one in respect to transforming, because the lessons from what we've done were relatively positive and the opportunities are on the table, and it's just for us to then transform. And again, it's not a blanket approach. We need to take a very detailed assessment of each of the opportunities and also assess the risks. I'd like to think that in a positive way, that the way that we operated with the Commonwealth over the last 2 years has been very positive to the degree that possible, but it is also open up opportunities to better integrate not only services, but also the data, and see if we can ever get to the point where we can really kind of start sharing more data to then streamline services and really kind of get to the point where we can remove some of the waste and duplication that we know exists in the system. And we'll get there, but having access to the data will certainly accelerate the whole process.
Thank you, Alpha.
Thank
Alex?
you.
Yeah, look, great discussion today. I think stepping back and thinking about it from the broader context of where the Productivity Commission is coming from, we're undertaking this 5-yearly review where we're looking at a range of things. But if we think about it, in terms of the services sector more generally, and healthcare is an important important aspect of services. William Bolmol identified the sort of cost disease issue many years ago, and in the sense that there's sectors which are going to be hard to get productivity gains out of, and healthcare may be one of them. And the reasons for that we've seen in the discussion today. There's so many moving parts, and detecting and implementing productivity gains is very difficult, because it's not like manufacturing where you just get more widgets per hour. It's it's the quality of the good that might be, or service that's relevant. It's the novelty of new services that might be provided. It's the consumer interface is very important. So you can't just automate things without there being some consequences and reaction from consumers. So thinking about it in that context, you can see that this is really the next frontier of where we think productivity gains, we'd like them to come from, but then what exactly they look like and getting costs down and improving service provision is going to be completely different, I think, in many respects from productivity gains in other areas that we think about more traditionally. So these are the kinds of issues that we're grappling with in this 5-yearly review, but it's been a great discussion.
Thank you, Alex. And Henry, if you may.
Thanks, Francesco, and thank you also to all the panelists for what I thought was a very rich discussion, which could go on for many more hours. I think the most important point I've taken away from today's discussion is that the way progress will occur is almost certainly not through the grand vision of the future, but by seeking many incremental improvements, putting elements into place which open options for future change. And one of the most important of those elements that can open options for future change and help create directions for future change is data exchange and learning. If we can advance in those respects, which have always been a bit of a problem for the Australian system, data exchange, in particular information exchange, and making full use of information, but also having ways of analyzing what data we have and learning from experience and sharing that experience, then incrementally we can get not quite to the ideal architecture that one might set out ex ante, but at least keep on improving a healthcare system, which I think it must be said for most Australians actually does continue to deliver. So thank you very much for inviting me, and thank you to all the panelists.
Thank you, Henry. Thank you, Brian. Thank you, Alex, and thank you, Alpha, to join us today. And really excellent discussion indeed. For those who've participated, certainly keep on looking out for our events, which on this debate series will continue on a monthly basis. In August, we will go to the other side of the Pacific and discuss the Chilean context, which is remarkably similar, although it had an acceleration in different directions in the past few years. Definitely with the recent elections, there has been a shift in focus in the changes to the constitution itself, which is bringing about a real overhaul of the healthcare system, moving away from, if you like, at least this is part of the debate which is happening in this very moment, as the voting will happen between now and September on the new constitutional card. So it's quite interesting because there is indeed a movement away from the, let's say, dual system, very similar to the Australian system, potentially in the direction of a more national health service type of model. But we'll talk with experts from Chile in a similar fashion. I encourage you to join us and participate. Obviously, for today's session, once again, thanks for the panelists, thanks for those who asked, and also for those who attended. For those who missed this and came in, as I saw during the talk, you can, of course, see this on our Value in Health Economics and Policy Group website, where you find also other media for you. So once again, thanks. Have a good evening and a good day to those in Europe, or any good part of the day wherever you are. Thanks. Thank you so much.
Thank you, Francesco.
Bye-bye. Ciao.
Thanks, everyone.